So my topic is on instability in elderly patients. This is my disclosures. so glenohumeral instability in elderly patients is a specific issue, quite different from other age categories because of a different pathologic spectrum and a specific surgical implication. Unfortunately, differently from other age groups, literature is quite lacking. Unfortunately, we have no strong recommendations on what to do in this kind of patients. And as you have seen, ESCA promoted and ESA specifically promoted, and LADO specifically promoted this consensus on shoulder instability. And one of these three work groups focused on older adults, more than 50-year-old. And 5 blocks of issues were investigated: the history, physical examination, imaging, treatment, outcome measures. And unfortunately, in this group, the strength of recommendations that we found in the literature was very low, grade C or grade D. Incidence of instability in elderly patients is 2028 of all acute dislocation. And recurrence is quite lower than in other age groups. And this data was recently confirmed in a study on 179 patients that reported a recurrence in 15% of the cases. This probably because the mechanism, the pathomechanics of instability in the specific age group is different from normal population, younger population, because there is a so-called posterior mechanism of anterior instability due to a tear of the posterior superior rotator cuff, then leave the humeral head to translate anteriorly without any violation of the anterior capsule. There is a small subgroup of patients that have an injury anteriorly on the subscapularis tendon and anterior capsule, of course. So you have to watch out this kind of pathologic findings when the rotator cuff seems to be intact. Other problems related to this age group is the osteoporosis. Osteoporosis that can cause fractures more frequently than in other age groups. So fracture dislocations, graded tuberosity fracture and displacement, or a standard fractures associated with anterior dislocation like glenoid bony Bankert or Hill-Sachs lesions. Nerve injuries are more frequent as well, and specifically transient palsy of the axillary nerve. 8 to 63%, according to the literature, is reported as prevalence of this associated injury. So this is another important warning for this scenario. Consider that a neurological injury can be present in a patient older than 40, and most of the times this injury is transient. What to do in acute dislocation? Closure reduction is advisable, but be careful. Do it under anesthesia and consider open reduction as well, specifically when you have irreducible dislocation or to avoid any fracture displacement. And consider a CT scan in emergency when a suspect of a fracture that involves also the proximal humerus, because you have a risk of displacement, further displacement of your fracture. So when you have just an isolated graded tuberosity fracture, the outcome is quite good. In case of large glenoid fractures or large Hill-Sachs defects, you have a higher risk of recurrence. Usually the graded tuberosity fracture is reduced after reduction of the dislocation. Then you just use a short time immobilization. The first goal is to avoid stiffness, which is more frequent than in younger patients. So immobilization is used just for pain management in the early phase. And then check for the strength deficit, residual strength deficits, because in this case you have a suspect of rotator cuff tear or a nerve injury, which is associated with a poorer outcome. When you have a rotator cuff tear after an acute dislocation, rotator cuff repair is strongly recommended. Bunker repair or combined rotator cuff and labral tear is more questionable, and according to the literature, recommendation is very low. So the repair of the anterior capsule is not really recommended. So what to do in this case? This is our algorithm. We just use a mobilization for a short time, and then start with the physical therapy to restore a range of motion and strength. If you have a good recovery, that's fine. But if you still have a strength deficit, check with an MRI or arthro-CT, depends on your preference, for a rotator cuff tear. If a rotator cuff tear is present and no neurological symptoms are evident, go to the OR and repair the cuff. If you have neurological symptoms associated, do an EMG, and if you have a neurological injury, consider surgery as well as soon as possible, because most of the time this is a transient palsy, and if you delay surgery, repair of a traumatic tear of rotator cuff is more challenging. If you have no rotator cuff tear, and the MG show a neurological injury, follow over time, because most of the time they can recover with the physical therapy. What to do in a case of recurrent dislocation? The main issues to be addressed are rotator cuff tear, which is very frequent, as we said, and the bone loss. Of course, if you have an osteoarthritis combined, indication for a replacement is advisable. If you have a glenoid bone loss with no osteoarthritis, a CT scan can assess the size of your bone defects. According to literature, if you have less than 25% of the glenoid width, a Latarjet is recommended. Otherwise, an allograft should be used. Personally, we use a fresh frozen Achilles tendon allograft with the bone graft, and we use the soft tissue part of the graft to reinforce the anterior structures. If you have a large humeral head bone loss, and the question is how large should be, and depending on the age, you can consider Latarjet, you can consider allograft if the size is larger, but in older patients, a reverse shoulder arthroplasty should be considered. So finally, this is our algorithm for recurrent dislocations. Do an MRI again and check for rotator cuff. If a rotator cuff tear is evident, try to repair it, try to fix it. If it's not possible because it's irreparable, according to the preoperative imaging, consider reverse shoulder replacement. If there is no rotator cuff tear and you have a bone loss, consider bone loss reconstructions. In the case of glenoid, major glenoid bone loss, Latarjet or allografts. If you have a large humeral defect, consider allografts for the humeral head or anatomic replacement. If you have no bone loss, this is the only scenario where an arthroscopic Bankart repair can be recommended. Thank you for your attention.